Morning everybody, welcome to the South East Perinatal Mental Health monthly webinar. For those of you that are joining us new today, if we will just run through quickly housekeeping. Please can you put yourselves on mute and turn your videos off unless you're asking a question or entering into the discussions. It just helps with the quality of the webinar. Please don't forget to raise your hands if you want to ask questions, and obviously also comment, put your questions, reflections, etc. in the chat function, and we'll keep an eye on that. I think Jenny's put a shout out, but do please feel free to introduce yourselves on the chat and have a chance to look through the participation list as well to see the breadth of people that are on the call. It's often quite a nice thing to do. And then just to let you know, obviously, as usual, we are recording the webinar for those that want to join us this morning so that they can watch it at a later date. So just to be aware of that. Okay, so next slide, please. So our topic area today is focusing on obviously the long-term plan, thinking about maternal mental health services and marginalised groups, but particularly focusing on women who have had babies removed. And this is a core ask of the development of the maternal mental health services. But when we reviewed all the bids in terms of the development of these services, it's definitely an area where systems are unsure how to address it. It's not covered by many of the bids currently because it is quite a complex area, and therefore we thought it'd be really good to do a focused webinar on it to support people in terms of their thinking and what we will need to do as we develop our maternal mental health services going forward. Okay, so we've got a packed agenda as always. Jenny and myself will kick off with a bit of a national update and some resources. Then we will move on. We've got some fantastic speakers as always. Claire is going to talk to us about women and infants in care proceedings within England. We've then got Di, who's going to discuss her report that she did, that we commissioned for the South East, in terms of what support is in place for women who have had babies removed at birth. And then Amanda is going to speak to us as part of our Hello, My Name Is feature in these webinar series in terms of the Pause programme, which is in West Sussex. And hopefully there'll be lots of time for questions and discussions in between. Thank you very much. Next slide, please. So I'm just going to kick off with a couple of key bits of information, national updates. Next slide, please. So I just wanted to highlight, hopefully many of you have are already aware of this event and have hopefully already signed up to it, but there's a Perinatal Mental Health Commissioners event being led by the national team, which is taking place on Friday the 18th of June. The details of the workshop are there in terms of including the link to register for the event. And we would encourage people, both perinatal mental health commissioners, but also maternity commissioners may also want to attend. It's really important that we have representation of commissioners from every single system. So please do sign up for that. And if you're, those of you that are in your specialist services, please make contact with your commissioners to make sure that they're aware of that event and that they are sending representation. Okay, next slide, please. There's also a series of workshops, events that are going on in terms of the development of the maternal mental health services for the programme managers and project managers that are involved in the maternal mental health services. Hopefully you're already aware of these sessions and you've signed up to them. There are a mixture of live drop-in sessions, and there's various question answer documents and other resources available on the collaboration platform. But these are the list of future dates coming up. And please, if you want to register or you want any further information, then contact Zoe, whose email address is included at the bottom, who represents Maternal Mental Health Services for the national team. Okay, next slide, please. Bit of a lovely. So I wanted to highlight the Health Education England Perinatal Mental Health Survey. You will have received an email from us on Monday giving details of the survey. There's a lot of information on that slide. I've just included it so that when you get the slide pack, you can look at it in more detail. But that information was included in the email that went out to our stakeholders. The survey is open for approximately 4 weeks through to the 16th of June, and they're looking to gain a vast amount of views from different parts of the system. So we would encourage everybody to please fill it out. I've got a bit of feedback, so if everybody could put themselves on mute, that would be appreciated. Thank you. This is obviously looking in terms of training and education. It will also impact on future training monies that will come out to the regions and that. So we would very much encourage you to do that. Thank you. Next slide, please. So just thinking about training, my next slide should be another training slide. Oh, no, it's not. It's something else instead. Sorry, so I wanted to highlight the Maternal Mental Health Alliance. The link on this slide is to a blog that was done by Elaine Amoa. It's a link to the blog and the research that she did in terms of thinking about the blockers for women of Black, Asian and minority ethnic women in terms of accessing perinatal mental health services. And as those of you in the South East will know, we're doing a lot of focus on that currently within the region. So we just wanted to highlight it. It's a good read. And then that will take me on to my next slide, please, which is going to be a plug for the work that we are doing in this area. So, as many of you are aware, we are doing a film with Good Guys Productions that did our film that we did last year on complex PTSD. So we are working with them to do a film thinking about the experiences based on the Embrace report for women of ethnic minorities. And we're particularly, this is a poster which some of you will have seen up in maternity units, but we're looking for 2 to 4 mothers with lived experience from across a range of Black, ethnic, Asian, South Asian and other ethnic groups from whom we can hear their stories or even part of their stories. We've worked with Good Guys over many years, and this will be done, the filming would be done really sensitively. It's not an investigation documentary, it's an education film. And they're very experienced with working with women, and also in terms of any footage used will be discussed in conjunction with the women for their agreement before it's used. But if anybody is interested in either sharing that story, their story to be part of the film, or know of women who may want to be involved through either their MVPs or the work that we're doing with Perinatal Health Voices, then please either put details in the chat box or contact us directly. They're in the process of filming at the moment, and we will be showcasing, launching that film. The premiere will be in September's webinar. Okay, next slide, please. So I think now I go back to training. Yes. So following on from the HEE survey that's out. I just wanted to just flag. So obviously we've got quite a comprehensive training package going on across the Southeast at the moment, of which I'm Fine Training, which is our next one coming up on the 8th of June, is now full. But I wanted to do a big ask really. So on the last couple of training sessions, training courses that we've done, at really short notice, either people have pulled out or they just didn't turn up on the day to the virtual training. And it's really important because for each of our training courses, we have a waiting list. So unfortunately, in those cases, we haven't been able to fill the places at the last minute because there just hasn't been enough turnaround. So my plea is please, 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 these are funded places. If you are not able to take up the place you need to give us notice, but there is an expectation that as we have funded them that you will attend. But if for any reason you can't, please let us know so that we can give a place to somebody on the waiting list. We're expecting this year that the bidding round from Health Education England for training is going to come out early. It's due to come out shortly. So we will, again, where we've got courses that have been oversubscribed, such as I'm Fine Training, we will be looking to put them on again later this year and into next year. So again, if there's specific things that you want us to consider in terms of putting on for training across the whole of the Southeast, then get in touch and let us know. Okay, thank you. Next slide, please. Next slide is about a Devon training opportunity. So Devon have been in touch to say that they have spaces left on the training that they are doing. It's a training course happening in October. It does have a cost implication. It's £45, but it's bespoke training from the College of Sexual Relationship Therapy, and it's focusing on psychosexual issues following birth and birth trauma. So if anybody is interested in attending that training and is able to pay for that, then details are included on the slide, and please contact them directly. Okay. Next slide, please. And I think I'm going to hand over to Jenny now. So over to Jenny. Thank you.
Morning, everyone, and thanks, Liz, for that. So last month has been quite a big month in terms of some significant documents being published for perinatal. So one of the big hitters is the NICE postnatal guidance, which was published on the 20th of April. And what's really lovely to see in this is that there's a lot of stress on the importance of the relationship with the baby. There's much more about attachment in there now. It stresses the need to talk about emotional well-being with mums at every appointment and to discuss their birth experience. So really tying in with the work of Perinatal Mental Health Services, our specialist health visitors, and of course the Maternal Mental Health Services. And there's also an expressed need for GPs to do that at the time of handover. So all good stuff in there and well worth a read. And then the Royal College of Obs and Gynae report we've just put in there, although it was back in February, but there is some really good stuff in there about vaccination in pregnancy, which may well be relevant to our audience as we go forward. Okay, next one, please. The Royal College of GPs has also published a report about postnatal maternal and infant care during COVID. As we are all aware, GPs are tasked to discuss emotional well-being at the 6-week postnatal check. However, below this is the NCT report, which has actually found that about a quarter of new mothers are not asked about their mental health at all at the GP postnatal checks. So for those of you on the call that are involved in education work to stakeholders, please let's fly the flag again with GPs that that's such an important part of that 6-week check about mental health. Okay, next one, please. We wanted to highlight the launch of the Path project. So this is a big piece of work. There's a new online sort of multimedia support hub, and if you go onto the website, you can click to be sent the newsletter for regular updates. So I think this is something that's really worth people working in this space to keep an eye on, because I think this is a big piece of work that's still developing, and there'll be some good resources on there for the women and families that we serve. And leading on from that, the bottom resource is a new website about perinatal mental health treatment. And the nice thing about this is that it's all evidence-based, and within the website, it will not only are they evidence-based, but it will tell you the quality of that evidence. And I think that is admirable, because there's so much available now online, but we don't always know the sort of assurance around it. But with the resources on here, they all do have an evidence base. So they're mainly self-help type materials for women and their partners, and that's well worth a look. Next one, please. Last but not least, I know that we've highlighted this report before from the Maternal Mental Health Alliance, but this little infographic we think was worth highlighting in its own right, because I think this is quite a nice one for you to sort of be aware of in terms of if you're needing to have conversations with commissioners, looking at your service development and your business cases. Okay, thank you. Next one, please. And we didn't tell her we were going to do this, but I do think one of our regular attendees, Charlotte, really deserves a special mention for doing a half marathon. Not only did she do a half marathon, it was awful weather, and she raised a whole load of money for pandas. So well done to Charlotte. Yeah, I'm liking the clapping from the audience. Thank you very much. Okay, next slide, please. So it gives me great pleasure to introduce Claire Mason. I know those of you who went to one of the Maternal Mental Health Service launch events would have heard Claire speaking, but we make no apologies for having her again, because I think that this work is just so important for us to hear and understand and be aware of. So without further ado, I'm going to hand you over to Claire for her talk. Thank you so much, Claire.
Thanks very much, Jenny. Good morning, everybody, and thank you so much for the opportunity to come and speak to you. I do apologise if you have heard this before or something similar, but like Jenny said, I'll take every opportunity I can to really raise the profile of the needs of this particular group of women, which I've been researching around for a number of years. So I'm from Lancaster University, from the Centre of Child and Family Justice Research, where I work as a research fellow. And what I'm going to do this morning is talk you through some key findings over a number of reports, which will really give you the background as to what we found out around women who do appear in care proceedings and are the cohort of women who in your services will be having babies separated from their care very close to birth. And I suppose what I really want to do is really make the case for why separation at birth should be seen as a birth trauma. I was part of the national reference group for the Maternity Mental Health Services and have really been advocating for this group to be included in this pathway. And I'm just so pleased to see that many of the early implementers and fast follow-on sites have got this group well within their radar. So next slide, please. So as I've said, and the next one, please. I'm going to be drawing across a range of studies. Everything I talk about today will be freely available down from our website, and the link to that is at the end. Next slide, please. So the first study that really focused on this cohort of women was a study that we published in 2018 called Vulnerable Birth Mothers and Recurrent Care Proceedings. And it was the first study that really was able to show the size and the scale and the experiences of women who reappeared in care proceedings. So this is a group of women who've had multiple sets of care proceedings, and we looked at a 7-year period. So we went to CAFCAS because they collect data on all care proceedings in England. And what we did was, rather than have a child-focused lens on the data, we flagged the mothers. And what we tried to see is, once they've been through one set of care proceedings, what were the chances of them reappearing within that 7-year period? It was a 7-year period just because of the nature of the data set. So we know it would be truncated in that there were some that would have already appeared before our kind of data set started. So this will be an underestimate. But there were 65,000 women in that data set. We then took a subsample of 354 of those women who were recurrent, i.e. had more than one set of care proceedings. And we went to 5 core areas, family core areas, and we read all the care proceedings associated with the children of those women, which was just under, I think it was about 900 sets of care proceedings. And then finally, we did interviews, so qualitative interviews with 72 birth mothers. Next slide, please. And the other study that I'm going to be drawing on is a current study that follows on really from findings from the Vulnerable Birth Mothers study, which really focuses on this issue of separation at birth. And it's come around because of what women told us about their experiences. They were very clear in those qualitative interviews that their experiences of being separated from their babies was very distinct from experiences of being separated from older children, not to say better or worse, but distinct. And we could see that there was real variation in practice across the country. So what we've done is the Nuffield Foundation have funded us, and we have developed a 4-stage study, which we are just finished data collection on. So we're working with 8 local authorities and their health trusts, and we've done focus groups with social workers, midwives, interviews with principal lawyers in all the local authority, focus groups with CAFCAS, focus groups with foster carers who look after newborns, and then face-to-face interviews with parents, which I've literally just finished last week. So we've spoken to 44 parents who've experienced separation at birth. So all in all, we've got insights across those 2 studies from over 100 women who have experienced this situation. Okay, so next slide, please. So to start off with, I just really want to talk to you about what we found out from the Recurrent Care Proceedings study, some of those headlines. And I suppose the really important thing to say is this isn't a tiny population. So women who reappear in care proceedings is 25% of those that appeared in the initial proceedings. So 1 in 4 have a chance of returning with a subsequent child within that 7-year period. And I suppose the relevance for today is that for 60% of those, they reappear with a baby under the age of 4 weeks. So once you've had one child removed, your chance of then having a separation at birth is incredibly high. And it happens quite quickly. So with 35% of those, the second set of proceedings was in a year, and for many there was an overlap. So they were pregnant again before the proceedings had concluded on their previous child. And in terms of what that means for the women's ability to access relevant services, and to be able to demonstrate the change that the local authority and the courts require is really challenging because it's such a short window, which is why services such as the Maternity Mental Health Service are so important. Okay, next slide, please. So the study that we're working on at the moment is the Guideline study. Is part of a series of work called Born into Care. And it started with a quantitative look at the data, because the way the DFE report data of children in care proceedings, they clump all the under ones together. So this pie chart shows the proportion of children of each of these age bands in care proceedings over a 10-year period. And it probably isn't a surprise to see that the biggest quantity are those that are less than a year old. So 27% of all children in care proceedings are infants under 1 year. But what we did, which was the first time this had been done, was try to separate out those infants. So if you just press down, I'm hoping another pie chart will appear to the right of that one. Just click to the next slide. It should just pop up. Yeah, great. So if you break those under ones down, you can see that 36% of those had care proceedings issued within a week of birth. So these are the newborns in care proceedings. So again, that's a sizable proportion of infants. So these are the women that will most likely have had care proceedings issued within a maternity context. Next slide, please. I think, could somebody mute? I'm just getting a bit of feedback here and hearing some coughing. Thank you. And this shows what we found over that 10-year period, and the newborns are that first blue line. So you can see that if we focus on newborns, there's been more than a doubling of newborns coming into care proceedings over that 10-year period. And in the next couple of weeks, we're going to be releasing an update on this, and it will show that that trend hasn't stopped. But also really important in this picture is that there's real regional variation, as we'll see on the next slide. So next slide, please. So you can see that over that period, the trends in different parts of the country is different. So, and there's a bit of a north-south divide, with the numbers becoming much higher in the north of the country than in the south. And there are many reasons for this, and we've done some regional workshops to unpick this picture and try to understand this, which again you can access from our website. Next slide, please. So I'm just going to talk a little bit more about the Guideline project. Could you go down to the next slide, please? And one of the things that we wanted to do to start with was, in our 8 local authority sites, was really understand what did the current guidelines look like around kind of the pre-birth period and removal at birth. And what we can see is that there are many different documents, but that in summary, they don't mesh together very well. So you have some that cover the pre-birth period, you have some that cover the kind of immediate separation period, and very little that looks at after the baby's been separated. But they have a real risk focus because most of them have been developed out of serious case reviews. So in terms of putting a lens onto the woman's experience in this space, these guidelines, where they do exist, are actually not that helpful in terms of thinking about support as well as kind of mitigating risk. Next slide, please. So across these 2 studies, as I said, we've spoken to over 100 women now. So now I'm just going to give you some real insights into what we've learned about the women's experience. Next slide, please. So from the case file study and from the women's own accounts in the interviews from both studies, we can really see that adverse experiences in the women's own childhoods are really common features. Over 40% of them in the vulnerable mothers study, the recurrent care proceedings study, had been looked after children themselves, and they had been subjected to a lot of maltreatment and neglect in their own childhoods, both within their own family circumstances, but also within the wider community. So vulnerability and secondary victimisation adolescence is also really common. And I think our conclusions of that study, and you'll be able to read it in the literature that I'll be sharing, is that actually when you look at their histories and how they've moved around services and moved around the system, they've kind of had lots of different labels applied to them and lots of different services as a result, but very few of them, if any, have really had anybody look at this complex trauma, complex PTSD that we think underpins many of their experiences. And so they've moved through the system being kind of offered various services at various points, but because of their adaptation to these experiences. So they may have developed different coping strategies, such as substance misuse, alcohol misuse, and are being in services that are dealing with that, but not really looking at kind of what's underneath that. And it's the same when they appear in services, child protection services, where they then be kind of are viewed through the lens of a maltreating parent, rather than through somebody who themselves it has experienced complex trauma. Next slide, please. So we really want to make a case, as I've said, that separation, being separated from your baby at birth, is a birth trauma, but the context of that is these are already very traumatized women who may not have had anybody who's really asked those questions about what's happened to you. Next slide, please. So if we look across the different parts of the system, given that commonly these women may have experienced a lot of loss and grief in their lives already, a lot of maltreatment in their lives already, we then put them into this situation where they're going to be really scrutinised within their pregnancy. And the pre-birth assessment and planning period, we hear a lot about people being concerned about concealed pregnancies and late presentations. Actually, our data from Wales, we've done a study where we've joined maternity records with court records, and actually the picture there is that most of these women aren't actually booking in late. I think people remember those with concealed pregnancies because they're so concerning, but they're a tiny proportion. And actually where a lot of the delay in terms of pre-birth assessment sits is within the system. So women talk to us a lot about kind of approaching children's services or booking in with midwives, but then just sitting and waiting, and they know that the clock is ticking and they know that children's services are going to get involved, particularly if they've experienced a previous child removal. So their time to show the change or receive the support is so short that the quicker we can get in and do that work, which isn't just assessment, it's intervention, the better. But actually the experience is that there are very few services that are working intensively in that space. If you take into account women's histories of complex trauma, then the relationship is key, and trying to avoid that re-traumatizing experience of having to retell your story is important. So continuity of care should be at the heart of this, but as we know, churn and turnover, particularly in social care staff, but also stretched midwifery services, makes this difficult. Moving beyond the practical, so I've talked about moving beyond assessment, but also moving beyond change being measured by the practical outcomes for the woman. So it isn't just about has she bought the things that she needs to buy for the baby. I mean, actually, that can be done very quickly at quite short notices, but there seems to be quite a focus on this. And when what women tell us is if that baby isn't going to become home to us, then what happens is the baby is separated and they then come home to a house full of stuff that just reminds them of that baby and adds to the trauma of the separation. These are women who are largely living in poverty. Poverty is the backdrop of most of these women's lives, and yet we're kind of measuring them by their ability to accrue things rather than really focusing on that attachment to the unborn fetus. The birth planning space. So I know from our midwifery focus groups, it's a real bugbear of many midwives that social workers work to estimated due dates rather than to term. And often birth planning is happening very late where children's social services are involved. But we're absolutely clear that no woman should be going into labour apart from those real exceptions, without knowing what the plan is likely to be. So if, and I know that they don't know until until there's a court decision, but if they know it is the local authority's intention to issue proceedings at birth, then the more planning and consultation that can go on with the woman in pregnancy, the better. And that includes knowing things like who might the foster carer be, and if at all possible, being able to meet that person. So we think that sharing that information and giving women some choice and control in that birth plan is vital, and it shouldn't just be a risk-focused birth plan. Okay, next slide, please. Women talked a lot about their experiences in the maternity unit. Again, their experiences is that planning around it felt very risk focused, so very much about who was allowed there, whether security were going to be alerted, etc. With less opportunity for them to think about privacy needs, for example, choice around did they want to be on the main ward, or did, if possible, they want to be in a private room. And women had mixed feelings about that. It isn't a straightforward decision. And I know a lot of that is about what resources you have available in a very stretched services, but this is what women are telling us. Having to receive news from social workers or have solicitors appear at your bed with really just a curtain to be pulled round rather than any access to private space was incredibly difficult, given all the shame and stigma that is attached to experiences of state intervention at birth. I'm sure as midwives, you will absolutely understand how difficult it is for a woman who, within hours of giving birth sometimes, is having to give instructions to a solicitor. And the way the system is and the law is at the moment, it means all this is happening in that immediate post-birth space, postnatal space. And there's real questions around ethical and humane practice. And we've got some horrendous stories of women being given half an hour notice to appear in court, being expected to get buses to appear in court, with very little thought being given to how she's going to get there, what emotional support she has. So the way the legal system is set up at the moment is incredibly difficult and very traumatizing for women. I've mentioned shame and stigma, but it's so central to when we're thinking about the long-term mental health for this group of women. Maternal identity. So in this space, how are women having an opportunity to start to build their maternal identity? So being supported to experience those firsts with their baby in the very way that any other mother would needs to be sort of central. And women did get a sense in some situations that midwives and other professionals felt really awkward around that if they knew the plan was likely to be separation. But actually, it's that maternal identity that women are telling us is the absolutely central thing that motivates change. So don't forget that even if this baby is separated at birth, they then have up to 6 months of care proceedings. So there is time then for women to really kind of try to motivate for change. And if it isn't in the timescales of this baby, it could be in the timescales of the next. There's some wonderful work we've uncovered across 8 health trusts around using separation at birth boxes, and we're working with the lived experience group now to develop that some more, working with 26 of the health trusts have signed up to work in a project with us to try to get these rolled out, in which women will get a sense of continued connection to their baby, even if that baby's removed from their care, through the use of teddy bears, blankets, photographs, etc. That space around the separation is absolutely a traumatic experience, but we can do things to mitigate against that trauma, and the small things absolutely matter. So how much conversation has gone on with the woman about the timing, about who's going to be there, about who she hands her baby over to. Simply the act of handing the baby to the midwife rather than the social worker can be huge in terms of what the woman is left feeling. Getting the opportunity to walk the baby to the hospital door, because that's what all mothers do. in terms of their identity as women and dealing with the shame and stigma, these things really matter. And being encouraged to breastfeed like other women are, being given a pump if they're trying to express milk, that might be a really important part of them holding on to their connection and commitment to their baby, choosing the outfit the baby goes home in. All these conversations are making a big difference to women's experiences of trauma in this space. And then we move on, next slide, please. And then we move on to postnatal support, which we absolutely know is missing. So we know that midwives do postnatal checks, but we also know that many of these women find it very difficult to engage with that. So to see a midwife when they've got no baby in their care. We know from the other work we've done around recurrent care proceedings and with the wonderful array of recurrent care services that are now in operation, that an assertive outreach approach that understands that women, given their complex trauma histories and this additional experience of trauma of separation at birth, are unlikely to step forward for engagement and engage in services. They need an assertive outreach approach. They need a flexible relationship-based approach. We can see from the women's accounts that complicated and persistent grief is common. So if you're thinking in your maternity mental health services about the reappearance of a pregnant woman who's already been through a separation at birth, the chances are that grief will be very live, and there are very few services that are working in this space to deal with that grief. It's a disenfranchised grief because it's not a grief that's commonly recognised by society. And women talk about, who do I go to talk to about it, because of all the shame and stigma attached to it. I've talked to you about holding on to maternal identity and using the maternal identity as a motivating factor. And we think the hope boxes, I'm pointing over there because I've got one sat here, could be a really good way of keeping that maternal identity alive. This loss, enduring sense of loss, continues. This isn't something that goes away. So when you're considering working with a mother who's pregnant again, the chances are that she will still be very much dealing with the loss of that previous child and the guilt associated with the next pregnancy. Women have been very poorly served by psychological services. We've got lots of accounts of women telling us that they come out of court proceedings but with a diagnosis, often personality disorder, diagnosis, emotionally unstable personality disorder common, and they cannot access the service they're being told they need. And I think again, there's real ethical issues. How we've got something in place where people are walking out of court being told this is what you need and they can't access it. Particularly if they're then contemplating reappearing in court with a subsequent child, not having been able to access that psychological therapy. They're being set up to fail. Their mental health is not good enough to parent, but not being seen as bad enough or meeting threshold for adult mental health services. And for perinatal services, they can't access them if they haven't got a child in their care, which again is where this service is so important. The experience of proceedings themselves is yet another trauma for the women, just because of the adversarial nature of that experience. We do have a number of recurrent care services now operating across the country. So I can see the wonderful Sarah Hurlem is here with from Stepping Forward at Oasis. You've got Foundations, another wonderful service. You've got Pause. So you've got in your area, you do actually have a number of recurrent care services, but at what point they're able to intervene depends on their criteria, but many won't get involved until the end of care proceedings. So we have got this kind of 6-month period where a woman's experienced a separation but isn't necessarily able to access those support services. We've just finished a mapping report around recurrent care, and I'll put the link in the chat so you can see what services are available in your area. Next slide, please. So we think the small things really matter in terms of reducing the impact. So thinking about a trauma-informed maternity service in the round, and giving choice and control, really showing empathy and sensitivity. And that means really supporting the midwives who are doing this work. Midwives have told us very clearly how traumatic it is for them. This isn't why you came into midwifery. This isn't the type of work that fits very well with a woman-centered experience. So how can we make this more woman-centered? How can we put the woman at the center of this and reduce the trauma? Next slide, please. But we also have some huge system challenges, and I'm not going to run through them all now because I'm aware of time. But time, workforce capacity is huge, both in midwifery and children's social care. Specialist skills and knowledge to deal with this group. Jenny outlined how tricky it is for some of these maternity mental health services to kind of move into this space. And is it being given a priority? They're very commonly seen as a resource intensive and difficult group to deal with for all the reasons I've said, but don't let that be the reason that they don't appear in your service, because these are probably the group that need this the most. We can see all the challenges around the legal processes. We're really trying to foreground alternatives to separation because we can see things happening across the country. Mother and baby foster placements, mother and baby assessment centres, places of safety. Do we need to be separating this close to birth? Big system issues. Worker churn really standing in the way of that continuity of care. And of course, cuts to services. Next slide, please. So just to finish off, just to let you know what we're doing next, having completed all the data, we're building the national guidelines. They're going to be published in September, October this year. We're doing the local implementation work to pilot those guidelines alongside the hope boxes in those that haven't already got it, working with those that do already have them. And we're also working through the NHS England Safeguarding Midwives Network to make some training films using our lived experience group to help midwives kind of understand this work more. Thank you very much for listening.
Thank you so much, Claire. We could probably take a quick question now, and then I might ask people to put any further questions in the chat. So has anybody got a question for Claire before we ask them to go into the chat box? It just feels to me like we're right at the start of this. I know that for you, Claire, it's sort of a much longer journey, but I think for us sort of collectively to get our thinking together about this group and how they're currently treated and how we can do it better, I think it's so vital that we get this right. Okay, so there's a question in the chat from Katie. Is this research being shared with social workers and local authorities?
Yeah, I mean, as I say, we're right at, we finished data, we're doing data analysis, we finished data collection of the guideline study, and then we're running these summer workshops with all the stakeholders to build the guidelines, and then there'll be a full report coming out in September, and we're working with the local authorities that are our pilot sites to implement those and in the maternity systems, and then we'll evaluate that and then look at kind of wider rollout. So yes, absolutely, it's a co-produced guideline, so both local authorities and the midwives in each area are going to be involved in developing those. I just wanted to give you some kind of early insights really because of the timing of you setting up these maternity mental health services. And I guess, Jenny, we're just wanting to do all we can to help. So, you know, are available to do what we can. And there is growing expertise in the recurrent care services as well. And I'll put into the chat the new website. So we've set this up with Research in Practice because we've set up a community of practice for recurrent care services. Zoe Milliez is actually coming to talk to them all tomorrow. So I think there's real opportunities for their learning to feed in at a local level into the maternity mental health systems because you've got some real expertise in your area to draw on as in other parts of the country. So yeah.
I see there's a couple of hands up, but could I ask people to put questions in the chat, and are you happy to answer them through the chat, Claire?
Yeah, of course I am. Yeah, and my email address is on the slides, so people can also contact me outside of this. At the end of these slides as well, there's a link to a film we made with mothers in the Recurrent Care study, which is well worth a look. It's only 10 minutes. And when the training film comes out from this guideline study, I will share that. We're making it in the autumn. And we're going to involve midwives who have already started work around developing pathways to work specifically with this group through the use of the separation at birth boxes, hope boxes, not forgotten boxes. They're called different things in different areas. So they'll be included in making those films. So we'll also share that.
Lovely. Okay, if I can move us on then, and we'll go into our next speaker. Okay, so one of the things that happened after I'd heard Claire talk for the first time, which was quite a long time ago now, is that I started to have a conversation with Liz about what have we got going across South East? What things are already in place? And we realised that we didn't really know. So to underpin the work for the scoping of the Maternal Mental Health Services, we thought that we would commission a report to just get a sort of baseline of what was already in place. And so now I'm going to hand over to Di Kitson, who's going to talk us through the findings of that report. Over to you, Di.
You're on mute, Di.
Okay, can you hear me now?
Yes.
Good. Fabulous. I don't know what that was about. I apologise for that. Okay, so I'm following on from Claire's fabulous, very broad talk and really concentrating on that we found out from doing a report across South East. Next slide, please. Okay, so I was commissioned to do a report looking at past practice and gaps across the South East region to help inform the scoping work for the development of the MMHS. I'm going to say MMHS if I can manage to say that rather than Maternal Mental Health Services every time. So this was looking, if you like, about initial work around preparing for the scoping work. And a lot of what we found in this obviously reinforces a lot of the work that Claire has done from a more academic sense. Next slide, please. Next slide. Okay, so the report was seeking answers. So we were very much looking towards not the women with the lived experience, but to professional staff. So do different disciplines who are involved feel confident that they have a clear policy pathway or procedure in place? Can different staff groups describe how they support the physical and mental health? What ideas do different disciplines have on the support base, and what examples of regional for this cohort, and what could be the role of the MMHS for this group of women? Next slide. Next slide. Thank you. Okay, so the overviews of the report were to establish a baseline of current support across the South East region, to highlight national and regional best practice, and we've heard a little bit about that already from Claire, and to provide a list of resources that might help inform the scope, and also, of course, to highlight gaps in provision and make recommendations. Next slide. Okay, so how did we do this during a pandemic? We were very aware that we were concentrating very much on the mothers whose babies were removed at birth. And we've heard that's quite a substantial number from Claire's work. So that was where we were putting our emphasis. We wanted to get this report done within a timely manner. So we went with the online SurveyMonkey questionnaire, which, as you all know, is a very nice, simple, quick, easy way of getting to lots of people. We sent this survey out to maternity services, GP, perinatal chapter, perinatal specialists, perinatal mental health community teams and local authorities. And we sent out over 150 sort of links to the questionnaire. Next slide, please. Bit of a delay on this. Okay. Then to, if you like, sort of build up the body of information within the report, we also carried out some semi-structured and you can see here the list of people that we spoke. Family nurse partnership, we know that they actually operate differently in each area, but we spoke to the Hampshire service. We spoke to Ormiston families. So although they are outside the southeast area, they have a reputation for some of the work that they do with deprived families and deprived communities. So we spoke to them. We spoke to Judy Shakespeare, who has a lot of experience in perinatal and mental health and is involved in Embrace. And she gave us an overview, if you like, from a GP perspective. We spoke to Pause, and you'll be hearing more about the wonderful Pause. Some fabulous information from foundations in East Sussex via reports that they prepare each year about their outcomes. We spoke to a health visitor who is a specialist in perinatal and infant mental health. We spoke to the lead, safeguarding lead midwife in Kettering, who has received an award, where their service has received a national award actually for not forgotten boxes. So another version of Hope boxes. And we spoke to birth companions who do some fabulous work both in prisons and in communities. Next slide, please. Okay, so just to give you a sort of rundown of the survey questions, we kept these, as you will see, extremely simple. We wanted to encourage people to complete the survey, but we also left a lot of the questions open so that people who are particularly interested or committed or passionate could give us a little bit more detail. And we certainly had that. We had a lot of enthusiasm and passion and ideas. So we were asking about if they were working without policy or guidance, how did they ensure quality of care, and what support did people think should be in place for this group of women? And if there was anything else they would like to tell us. Next slide. Okay, so you'll see the majority of our answers were from midwives, which was absolutely great because we were concentrating on this babies removed at birth, and obviously maternity staff are very much involved in this. And this was a range of midwives with different titles, from safeguarding mental health midwives, bereavement midwives, and people who labelled themselves just midwives. So we were pleased with that response. We made sure that we had a response from maternity services from each CCG, and also we aim to have, and we did have, a response from each of the perinatal mental health teams across the southeast. Okay, next slide, please. We actually, you'll see from this, I mean, it's a massive area and actually quite difficult to, if you like, collate all the probably fantastic work that is going on across the area. So, you know, we were perhaps a little bit limited in how we went out. You can see there are a lot of hospitals, there are a lot of different setups with STPs and ICSs. And one of the things we were very aware of that services such as drug and alcohol, and even other sexual health clinics, etc., seem to have different setups in different areas, which actually makes local areas quite difficult to pinpoint. We sent out over 100, I think it was 160 requests for online survey, and we did actually get about 64 responses, so we were actually quite pleased with that. Okay, next slide, please. Right, okay, so I'm just going to take you through some of the answers we had. Survey questions. I'm aware of the time, so I won't dwell too much on it, but because we were asking a lot of open questions, we then had to identify the themes that came through in the answers, and the themes were really quite clear. I mean, the first question, are you aware of any policy or guideline for this group of women? Actually, over 50% of respondents said they weren't aware, particularly of any policy or guidelines for this group of women. And even the ones who were aware of a policy actually put it, if you like, as a responsibility of other teams. So it might be safeguarding teams or bereavement teams. There's a lot of comment on the emphasis being on the child, not the mother. There was a lot of talk about, oh yes, this is a policy that's being currently developed as part of the bereavement pathway. And obviously there was a very common desire for a clinical pathway or protocol, without a doubt. Could you just click on for a bit more on this slide, please? So these are the sort of quotes, and obviously I've just picked a few quotes to sort of reinforce the themes that came out. And we've got a social worker quote here on grey area with less detail on the emotional support of the parent. The health visitor talks about the service following the child, not the mother. There was variance in how the health visitors felt that they fitted into this area of work and support for the mother. So that was quite interesting that there was some different opinions on whether they had a role, if you like, to fill here. Focus of planning is on safeguarding from a midwife. GPs, all of the GPs who answered the survey said they didn't have any guidance or policy or protocol, or they weren't aware of any. Safeguarding team, it's their remit. The perinatal mental health team were very confident that they had a lot of working experience, but have a clear written policy or protocol yet. But this particular team said that they were looking to have a policy and protocol. Okay, next slide, please. So if you're working without policy, how is this group of women supported to receive adequate physical health care? I mean, the themes that came up here, interestingly, there was a lot of talk of routine follow-up, so referral back to GP, follow-up by midwives. Obviously, there was a lot of talk about non-engagement. There was some description, if you like, of what would be described as flexible provision, where perhaps vulnerable women's team would do whatever they could to encourage women to come back to have their postnatal checkup. And the role of the community perinatal mental health team was discussed, the GP's role and the health visitor's role. Could you click on, please? Might need a couple of clicks, this one.
While we're waiting, I just have to say you probably need to speed it up a bit.
Yeah, fine, will do. Okay, well, the quotes in a way speak for themselves, so I'll just pick out I'll pick out a couple here. There's a lot of talk of invisible women from the GP. They felt that they often in and they're missed, particularly because they move location or trust. Okay, although midwives often think that the GPs are the ones that are doing the support in primary care. Next slide, please. Apologies for the delay here. Okay, well, the next question I obviously know is how are these women supported to receive adequate mental health care? And again, I mean, in a way, the themes are obvious. There was talk about, well, we're lucky enough to have a bespoke or a specialist service. People talked about that flexible, enhanced, adapted offer. People talked about referral back to primary care and acute mental health teams. Obviously, the gaps were mentioned. Staff attitudes and consistency was mentioned as an issue, and the perinatal mental health services role in this was mentioned. Next click, please. Okay, so talk of specialist team foundations with some very lovely positive outcomes. One of the midwives talked about local IAPT working with them if they will engage, and obviously, you know, there's immediately an issue here about whether a local IAPT service would have the resources to work with women immediately post-delivery. The other thing that I should pick out here is that the perinatal mental health teams had quite a varied approach to this across the region. So one team talked about they work with women for 2 weeks post-delivery. One team said 6 weeks. One team said that they worked until other agencies were involved. And one team said they wouldn't work with a woman if her baby was going to be removed. Okay, next slide, please. Okay. What support do you think should be in place? Again, this is fairly clear and really follows the themes that came through all the answers. Specialised bespoke teams, clear clinical pathways to achieve consistency, multi-agency collaboration, continuity of care, which we've heard about how important that is, aim to prevent future removals. So people weren't thinking just in terms of what was going on immediately post-delivery, but aim to prevent future removal, therapies and interventions. Okay, next slide, please. Okay, so there's just a few quotes here that I won't go through. I think most of you will be able to quickly read those and understand how this fits with those themes. Next slide, please. Anything else you would like to tell us? I think what we'll do is we'll go straight on to the next slide if we can, please. But staff had a lot to say actually on this area. And one of the areas that I would like to draw your attention, two quotes here really. It can take an emotional toll on healthcare professionals. It is the best thing for the baby, but you feel you are betraying the woman. Her heart is breaking, and non-compliance scenes involve police and partners getting violent, involving police and partners getting violent. And another quote, I really feel we need to be more honest. The few experiences I've had makes this 10 times worse. Women don't know it's happening. They become distrustful. They are humans and they deserve not to be lied to. Timing and plans need to be clear and efficient. So she has come round from a GA. So next slide, please. So I think that's sort of showing that actually, you know, the midwives really do feel in the middle of this, and they often don't know what the process is and what is actually going to happen. And they're often involved in quite traumatic scenes. Okay, best practice examples. I don't think I really need to go into this. The not forgotten boxes are the hope boxes that Claire talked about. And as I say, Kettering NHS Trust have won a national award. But I do know that in the South East, there's a lot of work being done on the not forgotten boxes. Next slide, please. And also it is worth mentioning that there was a lot of pride from individuals about work that they have tried to do with women in very difficult circumstances. We talk about systems and services. Okay, next slide. We'll go on to the next slide, please, bearing in mind the time. So key findings are fairly, if you like, follow on, almost obviously, really, from the survey and the interviews. Less than 50% had a pathway in place. Current gaps in service provision were highlighted, and even when pathways were in place, there were often no services to refer on to, or no appropriate services to refer on to. To be exclusively on the baby. Many cited GPs would follow these women up. However, GPs generally did not think that they saw this woman. They felt they were invisible. Widespread appetite for clarifying policy and protocol. Need for multi-agency working with better partnerships. And there was also feedback in the survey about poor staff attitudes to this group of women. Next slide, please. It's actually worth saying that the not forgotten boxes in Kettering, the safeguarding team felt that this had led to an improvement in the staff's attitude to these women, because it had drawn their attention to the fact that these women are mothers, and it also gave them a focus to work with the women around the birth of their baby. Okay, the recommendations, obviously these are just a few that I've picked out. They should be in a position to offer appropriate therapy to women. Multi-agency pathways should be developed for this cohort. Educating staff and stakeholders on the new pathways is going to be really important, so that people do feel clear and consistent about what is happening. And also some awareness around trauma-informed therapy will be very necessary. Bereavement midwives should consider extending their brief to include working with women who've had continuity of carer should be a priority. And I think quite important, really, conversations with different commissioners on creative ways to fund this area. And hopefully we might get some ideas on this from PAWS, who've done some fabulous evaluation work with the Department of Education, which I don't know if Amanda's going to mention, but that talks about savings within years. Next slide, final slide, please. Sorry, I'm trying to hurry up here. Okay, so future scoping work could become the catalyst to starting this multi-agency pathway work, helping women get access to the right therapy or support at an appropriate time. And I think the appropriate time and the timings of this is absolutely vital. Okay, thank you. I've put my email address there, so if anybody wants to email me any questions, please do. And the report, I think, will be available shortly. Jenny.
Thank you so much. Oh, Annie, can you take yourself on mute, Di? I think it might be you. Thank you. Yeah, that's better. And thank you so much for getting us back on time as well. I know that was a bit of a whistle-stop tour, but obviously the whole report will be available to all of the early implementer and fast follower sites that want to have sight of it, and we can put it on the Futures platform as well, so that anybody in the rest of the country, because I'm sure that these issues will be relevant wherever you are. So the recommendations, I mean, looking at this last slide, I think it's so important that the scoping work for the Maternal Mental Health Services, which is going to be bringing all the right people together, is used, as Di rightly says, as a catalyst to starting these discussions, because clearly there's an appetite there to get it right for these women. And I think it would be a lovely thing to come out of it, that we start to work more collaboratively and really put the women in the centre of what we're doing, rather than this current thing where everything's about baby and mum disappears off into the ether. Okay, I'll stop, get off my soapbox, I promise, and I will introduce you to Amanda. So if we can go to the next slide, and I apologise for the delay on the slides today. We'll sort that out before the next one. So Amanda Russian is a PAWS senior practitioner with West Sussex, and as Di mentioned and the report showed us so strongly, is that what these women really benefit from are these specialist bespoke services like PAWS that can offer them so much. So I'm going to hand over to Amanda, who's going to tell us about PAWS in West Sussex. Thank you, Amanda.
Thank you, and thank you for inviting me. I think really what I want to do is really bring pools alive, really, in terms of what support we give women in West Sussex. I'm loath to talk about the national picture other than what I would be able to forward you bits about that, but that's not really my bag. So I'm going to put a little bit of a, caveat there. What I can tell you is that currently there are 31 pools practices around the country, including Ireland and Scotland. And they're operating in 39 local authorities. So I think that just to give you an idea of the scope of where they are right now. As far as we are in West Sussex, could we have the next slide? Is that okay? Okay, so what we're about really and our sort of criteria is that we work with women who have experienced or repeat removals of children from their care. So exactly as we've all been talking about this morning. And we are funded in West Sussex by the local authority Children's Services. And that's clearly because what they're trying to do is avoid more removals of babies into care. And also to try and break that cycle. And I will talk to you a little bit about that cycle in terms of it's not just a local authority, care, children going into care proceedings and babies going into care proceedings. Actually, the on costs for us as a society are huge. When you think of the multiple adversities that Claire talked about, the justice system, the repeat offending, going into all lines of NHS services, and they're very expensive women. That's the truth of it. We have women that will turn up almost daily to A&E because they are unable to contain and regulate their emotions and have lots of suicidal thoughts. We have women that are revolving door patients and will go into those real high level expensive ways of containing their emotions in terms of hospitalizations, really, which can be really difficult and very, very costly. So I see this, and I was really interested, in what you just said, actually, Di, in terms of actually this isn't just a local authority care pot of money. It should really be spread around everybody that's affected, sadly, with these women who are really complexly traumatized, really. So in West Sussex, we've been running since 2017. And the way we got funded was from that pot of money from Children's Social Care, but it came about from just somebody in Children's Social Care going to a conference and hearing about these marginalised women and how something had to be done. And she came back, and just one person made a huge difference to that in West Sussex. And she talked to the right people that hold the purse strings when we were in the midst of a complete restructure of everything, which we are again. I'll put my hands up there. She decided that what she would do was really, really bang on the door of these people and say, look, we cannot allow this to keep happening. And actually, I've just heard there's a really good service nationwide, a women's charity that will actually help us scope. So they come in and actually scope with the local authority, Pools National. Where are these women? What are, how many have we got? And what are the chances of them coming back around to that system, which Claire told us those figures. So they're very strong, and really the evaluation speaks for itself. And so I've just seen that note pop up. Kelly Pierce and Kelly Wilkes did some amazing work, and I'll talk about that in a minute. Can we have the next slide? So just to tell you really what we've done and how many women we've worked with so far. So this is actually an old slide. Actually, I couldn't get hold of the original data, the data up to date, really, because we're right in the middle of doing that as Pools National. And so far in the years up to 2020, 2019 actually, we'd worked with 38 women who in total had 115 children removed from their care. And a lot of those, well, in fact, nearly all of those were recurrent removals. So that is quite a big thing that we focus on when we're scoping and when we're triaging who really needs that service. I mean, actually, my argument is they all need that service because they're all deeply traumatized women, but we have a small number of staff to work with them. So what, for us, I think what would be really helpful for me is to bring it alive a little bit and talk about how we do that. And I hope that's going to be helpful for everybody here. So we've scoped the women and we've decided that we are going to approach, I think the first and second times we approach something like 24 women. And I would have said probably 20% of that we got no response. And when I say we got no response, we are very tenacious in pause in the way we do things. So we'll start off by perhaps sending a text, trying WhatsApp, and then we'll go to the point of ringing, because we want to make sure it's a good time. A lot of the women that we work with are in domestic violence relationships still. So we have to be very careful about how we approach women. We'll then knock on their door. We'll put little nice cards that don't tell them much, but tell them enough that we're there and they can contact us. We will leave cupcakes, plants, and anything we can really to help these women feel like they're engaging with someone that they can trust and that they're starting that relationship in the best way possible with us. And what we're told by the women is that's so important, is that we don't come with an agenda, we don't come with a big form of assessment. We'll come in to meet them where they are at that moment. And actually at that moment, a lot of the time, they're in a hole, a very deep hole that they're really struggling with. I just wanted to pick up actually on what Diane Clare said around when we engage women. And I think in West Sussex, we're still learning that, actually, if I'm completely honest. There's a lot of learning still going on. We've been told by women in all of the women feedback we get and we collate is that they wish they'd got our service earlier. There's a little difficulty around that in terms of getting caught up in proceedings and how they might view us as a service. And so we're still grappling with that, but we're doing well, and I'll talk about the future for us in a bit more detail in a minute. So how long do we work with these women? So we work with these women intensively for between 12 and 18 months. It's a voluntary service, which is the most important thing. We don't want them to be told they have to do it. During proceedings, they've had a checklist of all the services they have to engage in. And I'm going to talk about Chelsea in a minute, and she brings that to life, because Chelsea is a real woman that has just literally 2 weeks ago completed her journey with pause, and I think it will really bring it to life over why these services are needed. And the way we work is we have a 4-month engagement period, which for a lot of services, and I know mental health services are probably going to take a sharp intake of breath, but actually, when we learn about women like Chelsea, you'll see why that's really important, that we have that time to engage them, to build a trusting relationship with them. So us as a practice, I think it's really important to say is that we're a very small practice. The pause model is quite a small model in terms of it can be expanded, but to begin with, we have a practice lead that works full time. We have myself, I work full time. We have 3 practitioners who I supervise that work full time. And then we also have a embedded coordinator that does a lot of the data collection, a lot of the administration, which means that my practitioners can go out and be on the ground with the women. And very often the visits they do with the women and where they meet them and how they meet them means that actually they need that time. To sit at a computer typing up notes is not helpful for anybody, and it certainly doesn't elicit change, actually. It might evidence change, and that's our coordinator's job, but what it doesn't do is actually help the women build that relationship, which obviously makes the change, really. So that's us as a team, and I really want to talk to you a little bit more about Chelsea's journey, because I think it really brings and highlights things. So Chelsea is a 23-year-old young woman. That's when we met her. She's now 24 and a half. Her journey, and she's asked me to share this with you, she's very keen on you hearing this, is that she lived with her dad until she was 4 years old. He was a heroin addict. When she was 4, he went to prison. She then went to live with her mum. Her mum was an alcoholic. And she didn't really notice her. These are her words, not my own words. She did this presentation herself. Her mum had loads of different men staying over who had been in prison for all sorts of things. Her mum described her often to her as a difficult child. When social services got involved, she was then sent to live with her nan, as mum didn't want me all the time, was what she told social services. She wasn't coping. And my guess is, and I don't know Chelsea's entire journey, but my guess is that this mum, her mum, maternal grandma, was also a deeply traumatised woman, probably. We know this is intergenerational trauma. She was then fostered privately with her best friend's parents because she did have issues. She admits that to us. And she said that really she wasn't really coping, her nan wasn't coping with her, emotional dysregulation through her trauma. She did really well at school, actually, Chelsea, against all the odds. And at 16, she came into local authority care, so less informal care. But she was then put into emergency temporary housing with a YMCA foyer. She was literally given the keys to her front door, which was a shared accommodation, and she described as being left to fend for herself, with no real life skills because of her upbringing. While she was in care, her dad overdosed and he died. And the phone call she got before he died, before he injected himself with a lethal dose of heroin, was that he needed her and that she should have done more to support him. She knows that he was equally traumatized and had shared his childhood with her. And she recognized that the drugs had kept those bad thoughts away from him. She described him as being damaged by the care system himself, and that he went on to damage me through the drugs and other not nice things. And I'm going to leave a little bit of that to your imagination because I don't want to overshare Chelsea's journey, but suffice to say, he pimped her out for his drug use and also helped her to start using drugs, and that initiated her to also be addicted to drugs for many years. At his funeral, interestingly, she met her first child's dad, and he was an acquaintance, a drug using acquaintance of her dad. Her child was born in 2017, which she described as the best moment of my life so far. I have never been happier. He was mine. I loved him so much. He was my family. He was what I've been waiting for. She was then put in a mother and baby placement with her child, as the judge had said I was doing so well, and that he didn't want this child to remain on a child protection register forever. So she did really well in that mother and baby placement. And I think it's really interesting to say that actually 95% of mother and baby or parent and baby child placements end actually with the child still being permanently removed, so 95%. So someone like Chelsea has done amazingly well to actually get that to be that 5% to keep her child at that point. However, she ends up in the 95% bracket. So she then got pregnant within proceedings, or within when she was at the child and baby placement. She didn't disclose that because she knew that would work against her, and she didn't want to be on the child protection register with her child. Because of her own past experiences. She then had her daughter, who was born in 2018, with a new partner. No social workers were involved. She left hospital in a normal way, which I think is really important to say.
Amanda, I'm just aware that I'm going to let you carry on, but I'm just going to say I appreciate that some people will have to leave now at 11:30, which is time we're due to finish. If anybody is able to stay, we will only run over by about 5 minutes because I'm mindful that people have to get to other things. If you have to leave, please feel free, do go. Obviously the recording will be available, but otherwise I'm just going to let Amanda finish off.
So basically, suffice to say, I won't go into detail, but then proceedings ensued. There was a bruise, unexplained bruise, and proceedings happened again. She describes herself as having a really toxic relationship with her partner. There was lots of arguments. She had severe mental health problems at that removal, due to the removal of the children. She also suffered postnatal depression, and she describes her world starting to fall apart. There was no support in place, and this is really interesting, and no support that she can remember being offered. It just didn't happen. I was confused. As services said I was doing really well, but I was not listened to and not believed at that time. I didn't feel I could be truthful with anybody. I didn't trust anybody because of my childhood. I didn't want to talk to anybody about that, and I certainly didn't want to talk to anybody that was going to report back to children's social care, which I think is a really interesting point when we talk about how these birth parents access meaningful support, mental health support, when they know that social services in proceedings, and that's going to be used in proceedings, you know, we have to ask ourselves what favour we're doing these women, really. She had a termination during this time because she was told by social care, if you keep this baby, you might keep this baby. If you don't have another baby, you might be able to cope. She did that for her children, her present children, but she didn't get her children back at all. She talks about her children, her life falling apart at that point. She was desperate to be given support, but was finding it so hard to leave the house because of the triggers of seeing children in the community with friends, that she just basically closeted herself away. So the access to those mental health services were therefore not accessible to her. She wanted them, but she was being asked to go to a place where she had to walk past the nursery where her child was. She asked the court for time to change, but unfortunately the waiting list for mental health services meant that none of that work was done within the timescales of the court process. She said that the children's best interest, in the best interest of the children, a year was too long in foster care, so she had a last contact in the 13th of September that year. I think it's quite a heart-rending thing to read, actually, her journey. But I think what I've taken away from that is actually, with Paul's support and building a trusting relationship with her practitioner, Trudy, over an 18-month period. This is Chelsea now, and I'm going to just show you a picture, actually, because I didn't actually manage to get these slides there in time. Chelsea now has a full-time job. She's volunteering for our service and Leaving Care service as a peer mentor. She has just been offered a promotion as a manager in her job. She's gone back to night school, and she is one of the most competent young ladies to talk about this. And I'd love to have her here, actually. She'd do it in a much better way than I can. What she said is that Paul's came along beside me. They believed in me, something nobody's ever done. I had grown up with my family telling me that I was crap, and that I wasn't going to amount to anything. Paul's made me smile and laugh. For the first time in a very long time, I didn't feel guilty doing this. Paul's helped me feeling okay about being happy and feeling I have hope for my future. For the first time ever, they have allowed me to make positive changes in my life already, and I intend to go on with these. If I had not met Paul's when I did, I would have had another baby, or I would have killed myself. It's as simple as that. So I suppose what I want you to go away with is to try and think about within your services in East Sussex, and I'm more than happy to help any way I can. There's a really good report that Paul's National have just done, a bit of research with women that have gone through their Paul's journey or are currently in their Paul's journey, and it gives really clear recommendations. Can I have the next slide? And I think this sort of sums it up, this slide, and there's lots of slides and they'll be sent round, I'm sure, but actually we need to be thinking about these women in terms of during their journey of pregnancy, before, during and after, essentially. And it's really in this report, which I really urge you to read, especially as commissioners, is actually, it's really clear what these women are telling us would make a difference, actually. And a lot of it is not rocket science. A lot of it is, it's hard slog, but it's also the magic that makes things happen. And I really want everybody to be on board to try and make these small changes. And I've made lots of suggestions, which I'm not going to go through because I know we're literally just about to finish. But some of them are very, really small changes that we can do that will really make a difference to this group of women, I believe.
Thank you, Amanda. Jenny, you're on mute.
Yeah, I was just saying the same. Thank you so much. And for those who have stayed to hear Amanda to the end, in Amanda's slide pack, which will come out, there are a lot of really good recommendations for our services that are really worth going over. But Amanda kindly tweaked the presentation so that we could hear that service user story. Okay, Liz, I'll hand it back to you to finish off, but thank you so much.
Yes, thank you, as Jenny said, to all our speakers today. Such an important topic and so important for us to get right. So just to let everybody know, our next webinar is the 30th of June. And that will be on whole system collaboration and health visiting. Thank you to everybody who has stayed on. We appreciate that we've overrun and we know how busy everybody's schedules are. We'll be sending out the recording and the slides shortly. Thank you for joining us all this morning and enjoy the rest of your day. Bye-bye.